Good morning. Welcome to the AAU conference. My name is Dr. Betty Nantongo. I'm an anesthesiologist at Cure Children's Hospital of Uganda. I'm going to discuss life after ICU, Uganda's perspective. That will be our outline for the discussion. So intensive care medicine is rapidly growing because critical illness is a major component of the global burden of disease, especially in our setting. Putting in mind of the COVID-19 pandemic that has brought to light the use of intensive care, not only to the public, but also to the health workers as well. We've seen an increase in the number of ICUs in Uganda. A study done by Atumanya et al. Assessed the current capacity of intensive care units in Uganda. It was a descriptive study countrywide that looked at the functional state of the ICUs. The study showed about 55 functional ICUs, about 12 functional ICUs with 55 functional beds in Uganda. But this is quite an improvement from the previous study done by Kwizera et al. That showed only 33 beds in 2012. So meaning there's an increase in the number of ICU beds and hopefully access to intensive care medicine in the country. Apart from this, there's been a Ministry of Health and also an AAU initiative to operationalize ICUs in the country that has been ongoing, especially at regional referral hospitals, meaning we'll have so many patients accessing critical care. If so many patients will be accessing critical care, that brings in light the post-intensive care syndrome that we should know about. And this is a new or worsening impairment in physical, cognitive, mental health arising and persisting after hospitalization for critical illness. So patients go through an ICU and then you see a worsening impairment in their physical and cognitive and also their mental health status. So post-intensive care syndrome has so many things that include functional disabilities, things like ICU-associated weakness, cognitive disorders like sleep disorders, things like memory loss, attention loss, reduced executive function, and also reduced mental processing speed that we see, not only for the patients, but also for their caregivers. All this leads to related quality of life in these patients. So what happens to ICU patients who survive, ICU in Uganda? We looked at a study, we did a study that looked at in-hospital patient mortality after ICU discharge and associated factors, a retrospective cohort study in selected tertiary hospitals in Uganda. We looked at 3 tertiary hospitals. We reviewed about 1,698 files of the patients that were admitted between January 2018 to December 2019. Among these, 644 patients died in ICU, putting the in-ICU mortality to about 37.92%, which is still the same, which is still comparable to all the other previous studies that looked at in-ICU mortality. So among these patients, we were able to analyze 711 patients. The mortality, the in-hospital mortality after ICU discharge was about 14.9%, meaning about 85.1 patients are actually discharged out of ICU to their homes. What we don't know is for those who are discharged to their homes, what happens to them? How is their quality of life? How are they integrating in the communities? Fortunately, there is a study that is ongoing with one of the students at Makerere University that is going to look at the quality of life of patients after ICU discharge. In the developed world, so much has been done in this area, like the brain ICU study that looked at the long-term cognitive impairment after critical illness. So in this study, patients that had respiratory failure and shock were included. They also assessed in ICU delirium, and about 74% of the patients actually had in-hospital delirium. 40% had global cognition scores that were 1.5 below the ASD at 3 months. That is similar to patients who actually have moderate traumatic brain injury. 26% had scores at about 2 ASD below the population, which is similar to patients who have mild Alzheimer's disease, meaning the functionality of these patients is actually affected, and some of them may not actually go back to full functional state even after 12 months. Delirium was independently associated with worse global cognition and also worse executive function among these patients. This is a study that looked at ARDS survivors. It's a review for very many studies for patients that had acute respiratory distress syndrome in ICU, that survived and were discharged at home. This review showed that actually a very big number of patients do not fully survive ICU, do not fully go back to their functional state. It showed that 70 to 100% of patients that survive ICU have low cognitive function, and up to 80% to 1 year, which passes up to 1 year in 80%, and up to 20% in after 5 years. Things like mood disorders, including like post-traumatic stress disorder. Some of these patients do not actually go back to full functionality. Not only the patients, but also their caretakers, their family members, meaning that we need to integrate care for also the family members of these patients, multidisciplinary and modality longitudinal follow-up for both the patients and their family members. So this study is closer to home, experiences of ICU survivors in a low middle income country. It was a study in Sri Lanka that showed that among these patients, most of them were actually grateful that they survived ICU. They are able to live. Most of them didn't really mind about their functional state. However, they talked about some stressful experiences in ICU, painful experiences, and some of them actually were worried about the future, what would happen to them after they've been discharged from the ICU. As I've said, we don't have much information about patients who have been discharged in our setting, who have been discharged home in our setting, that we need to really look into. We need to find out what is the quality of life of these patients, and also find ways of integrating their care even at home, so that they can obtain full functionality post-ICU discharge. Prevention of post-ICU syndrome is very important, and this starts right away from ICU care. Managing delirium in these patients, managing their pain as well, and also looking at early mobility programs, physiotherapy, early psychological interventions, and also focusing on favorable nutrition, things like ICU diaries, improving the quality of sleep in these patients. All these will later impact their cognitive function, even very many years after they've been discharged from the ICU. Management also, we should look at assessing and also diagnosing post-ICU syndrome, and also putting rehabilitation programs post-ICU, starting from in-hospital all the way to discharge. Prevention can also be summarized in all this. In the ICU stay, look at the delirium and also pain management of these patients. Make an ICU discharge plan on advance. In hospital, ICU outreach teams, rehabilitation within the hospital, social support groups for family and caregivers, and also as a need for other specialties like psychologists and occupational therapists, social workers, so that they can also manage these patients as well. So for post-discharge at home, usually we target patients return to their baseline and also planning for any sudden changes in their health status as well. So it's important to follow these patients up even in their communities. So in conclusion, post-intensive care syndrome is a growing public health issue, and there's a need to emphasize a prevention of cognitive, physical, and psychological sequelae of ICU care as well. So we need to look at research for risk stratification of the patients, tools to measure outcomes of these patients at home as well, and also to standardize follow-up approach for these patients in their communities. So I'll end by this quote by Gordon Dunstan: the success of intensive care is not therefore only measured by statistics of survival, as if death is only a medical failure, but also measured the quality of life that is preserved or restored. Yeah, so any questions are welcome. Thank you for listening. Those are the references.